it is more about, just get the slideshow. So it is, I think, the continuation of what Dr. Deshpande says, that's basal insulin intensification with the prandial insulin, a step approach wise progression towards glycemic control. I'll make sure I'll not repeat what has been already been discussed. So there have been, it's as this slides clearly highlight, insulin is more sometimes arts and trying to work around the patient perspective than just the pure science, which is true in medicine itself. You have to modify your science knowledge and accept and move on into what the patient would accept normally, because this is, in a challenging times, as was discussed, that steroids use has gone up. Thankfully, it's less in Delhi, but the spurt of mid-April to end of May was a terrible time for the country and terrible time for the Delhi, and terrible time for us as well, where the use of steroids have gone up dramatically, and at the same time the use of insulin has gone up as well. But at the same time, this is, how do you add and when do you stop basal insulin, and the over basalization, as the word which was used by Dr. Deshpande. So need for intensification of basal insulin therapy is the decline in first phase of insulin secretion post-meal and prandial hypoglycemia, and post-parental hypoglycemia makes a significant contribution to the glycemic exposure. The significant post-prandial glucose control, if you want to achieve an HbA1c of around 6 or around 7, it is important that we just not control the fasting. With the basal insulin, you can achieve the fasting, and once you approach 30-40 of insulin, which is around 70 kilograms, gentlemen would require. Going beyond 40, it means you are doing something wrong, and you have to start thinking of adding a prandial insulin so that, you can bring the HbA1c down. The large data on that post-parental hypoglycemia tends to cause increased cardiovascular mortality. But though there's no data that if you bring the prandial down, the mortality tends to go down. And, and it's very important to understand that that the data is not there because we didn't have much monitoring device, a continuous glucose monitoring. We have CGM devices that what we have currently. So I think, the data is going to emerge more in next couple of years' time, where how the post-parental benefits the cardiovascular outcomes, or for that matter, microvascular outcome as well. So when to stop titrating basal insulin is very important. When to stop it once, I think Dr. Deshpande has highlighted something for a 70 kilograms, 30-35 units of insulin. Fasting is fine, post-parental high, HbA1c high. That's the time that you start getting into the prandial mode of adding basal insulin. Option for intensifications for basal insulin, there are two options. You add prandial, we call it basal plus, means one long-acting insulin, and you add one rapid-acting or a regular insulin with the basal on the top of it, or you switch to premix insulin. So basal prandial intensification, the physiological way to intensify insulin is to mimic normal pancreatic insulin secretion, which is the first phase of insulin secretions, and prandial tends to control the post-meal. I am a big believer of basal plus, basal bolus, or for that matter, GLP receptors agonist to control the prandial glucose control, because the flexibility that what you want, and you want aggressive titrations, to want to bring the HbA1c to 7, it is very important that you add with the one main meal, which is largest meal, to cover the additional need of insulin. So defining the largest meal for the prandial insulin secretion in the basal plus regime, the OPIL study, the higher proportion of patients achieved targets less than 7% in the main meal group, both the study groups showing significant decrease in HbA1c. So it is, you can do a breakfast, it is also tradition that you will feel, particularly in a pregnancy setting, the post-breakfast tends to be the highest. At the same time, across the world, the breakfast, people do consume highest carb ratio compared to the carb protein ratios or the fiber intake. So it's very important to understand that you can pick up the largest meal. Some people do take 2 main meals, and sometimes the main meal could be the 11 o'clock in certain people, even in Delhi, a large number of people taking just 2 main meals. You can give that insulin with that 10 o'clock-ish lunches, breakfast meal, or you can with the breakfast or the main meal. The largest meal for the prandial insulin intensification in the basal plus regime in OPIL study Neither it has it has weight advantage with neutral advantage, neither the instance of hypoglycemia. So if you look at the, adding on the main meal, there's no extra disadvantage of hypoglycemia or weight gain. So the OPEL study has clearly defined that step was intensification of basal insulin, and a single glucagon, which is one rapid-acting insulin injections, improve the control. And when the glucagon was administered at breakfast or the main meal, equivalent improvement in HbA1c could be achieved at similar hypoglycemic risk. And the similar study autonomy to titrate prandial insulin in a basal plus regime. So study was designed with an HbA1c of 7 to 12. 6 weeks basal insulin optimization. If the HbA1c is not achieved by 7, then you add a prandial insulin, can be effectively and safely initiated by either 2 self-titrated logarithms every day or after 3 days. And in a clinical practice, you can use it 3 days or every day by one insulin. And overall hypoglycemia has been not that high compared to when you add the titrations. And the basal plus approach allows the intensifications and empowers self-management. It's very important that one thing is there, if you're using, for that matter, sulfonylurea or for that matter, insulin, if the patient's not doing glucometer testing and not optimizing insulin titration, no point in initiating the insulin. Either you titrate or the patient titrate. And if you ask patient to titrate, you are generally more successful. Sometimes we tend to start titrating right at the beginning of initiating of insulin. I tend to sometimes in certain patients, don't tell them titration, call them, start 10, 14 or 0.2 per kg body weight and tell them to come back after 5 days time, and the educator can handle and we can start titration later, because the whole logistics of glucometer testing, keeping the insulin. So titration needs to be taught at maybe at the second chapter rather than book chapter number 1. It's very important that it allows patients, so the intensification empowers the self-management. So enable to decrease the glucose variability as with the lower rates even not happen. The slow titrations, fast titrations, you have to, this is again an art. You don't have to do it every patient's aggressive titrations. Depending upon the patient, the family support, the acceptance of insulin, you can go slowly. So the basal plus versus premix intensification approach, where do we stand today? Several non-inferiority studies have compared the safety and efficacy of treatment of intensification with the basal plus and premix insulin, and some showed favorable efficacy in terms of HbA1c levels and lower hypoglycemia with the glargine 100 and 1 prandial insulin on a stepwise increasing the prandial compared to mixed insulin. Some showed similar outcomes. So there are clearly the basal plus insulin 10 and weight neutrality effect and overall incidence of hypoglycemia approach in a premix insulin is generally higher compared to basal plus regime. So the premix insulin is a complex because it's more time consuming. You have to explain more patients about the titration, especially the prandial. It's very difficult because you have a 30-70 or a 50-50 regime. And particularly if you want to use premix insulin, I would tend to go more for a 50-50 in the morning time and 30-70 at night time, because the nighttime hypoglycemia is difficult and you have to explain insulin very clearly. But it's not that you can't use premix insulin. It is, but the titration becomes very difficult for the patients because you have to titrate not simply the fasting, also the post-meal, and sometimes you get into this complexity of the post-meal higher and the fasting going lower, which is a very common phenomena with the premix insulin. With the basal plus, you can easily titrate the boluses, which is the rapid acting on the regular insulin. Post breakfast or post dinner, you have already initiated 1 boluses with 1 insulin. And obviously in type 1 diabetes, I think there's no discussion that you have to use basal bolus insulin. Patients losing weight, osmotic symptoms, HbA1c very high, on steroid therapy, requiring large doses of insulin, patient needs to be going into it. It's my very common practice that all new-onset diabetes with HbA1c approaching 9-10 above almost always offer insulin therapy. They tend to work really good for most patients. And the acceptance of insulin in post-COVID era has really improved. So a large number of patients getting hypoglycemia, it's very important to understand the basal bolus regime. You don't have to go for basal plus, you can go basal 2 or basal 3 plus. Every patient don't have to have 3 insulin injections. So basal bolus therapy or the premix, the basal bolus gives superior glycemic control to the premix insulin. In a study of patients, which is called LACE study, an insulin glargine plus glucin versus premix insulin. As you can see, the change in HbA1c, has been a difference in HbA1c and compared to the patient. And the hypoglycemia, as you can see, is much less compared to the premix insulin. The basal bolus therapy versus co-formulations, a combination of insulin glargine and prandial insulin achieved similar glycemic control treated to IDEC and BID co-formulations. So as you know, the Ryzodec is a co-formulations compared to basal, but the basal plus gives it advantage. And the step-by-step IDEC was a glargine 100 ISP, which is a rapid-acting insulin trial compared the efficacy and safety. It is shown that achieves a similar glycemic control. So advantage of basal prandial intensifications is mitigations of postprandial, less hyperglycemia, weight neutrality, dose titration, both the basal and prandial insulin, relatively more user-friendly. Titrations can be easily be taught and can increase the step-based manner. And overall, it is you who are going to decide what the patient tends to prefer and how much patient is going to titrate, and ultimately achieving the HbA1c to achieve the target control. So the stepwise basal prandial intensifications approaches fulfills all these criteria, and stepwise insulin prandial intensifications approaches offers a lower risk of hyperglycemia. So basal prandial regime made easy. So using a rapid acting analogs, not regular insulin, because titrations are much easier with analog insulin, less hypoglycemia that you can't. It's not that you can't use regular insulin, but yes, the advantage of analog, the timing of the meal, because you can titrate the patients accordingly and start with 1 shot of insulin and titrate accordingly. Titrate 160 to 180 and 2 hours less than 130. So add in second and third mealtime insulin injection if needed, if the blood sugar postprandial is higher. So if the patient is on say 30 unit of basal insulin and you're getting fasting of 100. And the main meal is breakfast, and post-breakfast is getting 300. You can start approximately 1/3 of the dose. You can start with 6 and 8 units of a rapid-acting insulin and up titrate accordingly. So intensification of basal insulin therapy recommendation by the ADA practice when to stop titration, that when you're achieving an HbA1c and insulin of a 0.5 unit per kg body weight, then you have to think that this regime is not good enough, and just intensification of basal insulin will not work. You have to think of prandial insulin or a premix insulin, but basal plus or basal 2 plus or basal 3 plus, which is classical basal bolus regime, starting with insulin intensifications with 4 to 6 units, depends upon how much patient is taking, and according to the weight, and up titrate accordingly to achieve the target of HbA1c. So intensification of basal therapy recommendation by RSDI when to stop titration, that's what's been more or less similar guidelines according to international criteria as well. So the key messages are that timely basal intensifications, critical for sustained glycemic control, adverse metabolic legacy effect, and adoptions of prandial insulin is more physiological friendly, patient friendly, doctors friendly, titration friendly as well. So back to the chairman, please.